I thank the organizers for, on behalf of all three of us, to give this opportunity to chair this session. This is a very relevant topic, and in our OPD practice we come across this, and must for all pediatricians to plot the growth charts and then counsel the parent regarding the requirement for further investigations. So these are the first line investigation what we come across to do in a child with short stature, growth chart and bone age. So we are looking forward to hear more updates regarding these simple tests, how to go about further, from Dr. Supreetha Shetty.
Good morning everybody. So today my topic is growth charts and bone age practice pearls. So both bone age as well as growth charts are very important in our day-to-day practice for pediatricians as well as endocrinologists. So what is important when it comes to growth chart is that we select a appropriate and a very accurate growth chart which gives us very good information on the child's nutritional status as well as the growth. So up to 5 years of age from birth, we can use the WHO growth charts. So we have the charts for weight for age, length for age, head circumference and weight for height. From 6 to 18 years of age, we can use the IAP chart. So the best chart to plot the growth of a child is the local available growth references. So we have the IAP charts which are designed for our Indian children. So we have charts for weight for age, height for age and BMI, which we can use for our day-to-day practice. So next important thing is what are the things that we plot on the growth chart. So first is the height as well as the weight percentile. So this will tell us the absolute status of the child, that is whether a child is in the normal range of growth or is he falling below the third centile either in height or weight, which could indicate a need for follow-up or further workup, or if it is going above the 97th centile, which is on the higher side, which again might require evaluation in certain cases. The next most important parameter would be the mid-parental height. So this will basically tell us the familial effect or the genetic potential. So we always compare the growth of the child with respect to the genetic potential that we expect the child to catch up or grow to. So this would be another important parameter. Clinically, from a practical point of view, the other parameter that is important is the height age as well as the weight age of the child. So this is of importance to us in giving us the clinical clue. So this would tell us the nutritional as well as the endocrine effects. So based on the height age and weight age, we might be able to differentiate clinically whether this child has an endocrine cause or a nutritional cause, either for short stature or for him being overweight or obese. So to plot the growth chart, the first requirement would be select the appropriate and the right chart. The next thing is how do we mark it. So the best way to do it is just by using a single dot. So we shouldn't be using a circle or a star, because on a long term follow-up it would be more crammed up, and that wouldn't be the right way to do it. So a single dot is what we would want to see. So if at all it is falling within this range, it essentially means that the child is in the normal range for growth. Anything below this line would mean that it is on the lower side. Anything above this would mean that it is on the higher side. So mid-parental height, again we calculate based on the mother's and father's height. The average of the parent's height plus 6.5 would be for boys and minus 6.5 would be for girls, both in centimeters. So if we take this example, we have this 12-year-old female child. So if we look at the height, it is within the range of normal. And then if you see the mid-parental height, it is around 161 centimeters. So we can plot the mid-parental height at 18 years of age. That is what we expect the adult height to be. And then for the target range, we can plot it plus or minus 6 from the mid-parental height that we have calculated. And then this is what the projected height would be. That is, assuming that the child has the normal growth velocity, this is how we would expect him to grow. And this would be the range of normal with respect to the mid-parental height for this particular child. So essentially we would want the child to grow along this line and reach the final height which is here and which very well falls within the mid-parental height range, which indicates that for the genetic potential of the child is growing adequately. Next, coming to the height, age and weightage. So this is basically the age at which the current height or weight meets the 50th centile. So if we take an example, we have a 10-year-old boy whose weight is 45 kgs and height is 130 centimeters. So to plot the height age of this child, we need to see where the present height will meet the 50th centile. So we might have to either extend it backwards or in some cases forwards. Here we extend it behind and it meets the 50th centile. So the height age plots somewhere around 8.5 years. So this is the height age for this child. Whereas for the weightage, if we see, we have to extend it forward to meet the weightage and then we drop a perpendicular. So this child has a height age of 8 years 6 months, which is less than the chronological age, whereas the weightage is 13 years and 6 months, which is advanced when compared to the chronological age. So this is how we would plot the height age and the weightage. Coming to the next example, so we have a 12-year-old female whose height is 132 centimeters. So we can see that it is plotting below the 3rd centile. So if we look at the absolute status of the child, it looks like she is short for the population. So her weight is on the lower side of range of normal. So it is between the 3rd and 10th centile, which is on the lower side, but it is still within the range of normal. Her mid-parental height is 146 centimeter with the range between 140 to 152. So this would be the mid-parental height range for this particular child. And if you see the height, even though it is falling below the 3rd centile, it is still very well within the range for the mid-parental height range. And now when we see the height age, we see that it is less than the chronological age. So the height age is 9 years, the weight age is also less than the chronological age, and when we do the bone age, it is around 11 years. So here we have a child whose height age and weight age are both less than the chronological age, and the bone age is almost equal to that of chronological age. So when we follow up this child, what we see is that her growth velocity is normal, and finally she is reaching a final height which is below the 3rd centile, but which meets the mid-parental height expectation. So this is typically what we see in a child with familial short stature. So we will have to follow them up to document the normal growth velocity, and we might also have to rule out other organic or hormonal causes. So this is how a child with familial short stature would plot. So up to the age of 1.5 years, they might be in the range of normal, following which they might drop down to their genetic potential and then readjust and then continue to grow with the normal growth velocity, meeting the mid-parental height expectation, but they might still be below the 3rd centile with respect to their height. So another child, a 12.5-year-old male whose height is just below the 3rd centile, and his mid-parental height range is between 163 to 175 centimeters. So if we see his height, it is definitely on the lower side, below the 3rd centile, and it is also not within the range of the mid-parental height range. So if we see his chronological age, it is the height age is less than the chronological age, whereas the bone age is almost equal to that of his height age. So this child, when we follow him up, what we see is that his growth velocity is normal. Sometime later he has a growth spurt and he shoots up in height and then finally meets the mid-parental height expectation. So this is what we see typically in a child with a constitutional delay in growth and puberty. So these children, they have a later growth spurt, they go into puberty later, they might be on the lower side when compared to when we see the height, but they grow closer to the 3rd centile and then have a growth spurt and then they catch up and meet the mid-parental height expectation. So even these children at birth until around 1 to 1.5 years of age, they will be in the range of normal, following which the height centile might drop down and then they continue to grow with the normal growth velocity and have a growth spurt during puberty and they meet the mid-parental height expectation. Even in these children, the other causes like other organic causes or hormonal causes need to be ruled out. So for growth velocity, what we can do is we can use the height velocity or growth velocity chart. So here what we should remember is 25th centile is what we take as the normal. So at any age, if the growth velocity is falling below the 25th centile, then it is considered as suboptimal. Next, this is an 11-year-old child whose height is around 120 centimeter, which we can see is much below the 3rd centile, and her height age is also delayed, the weightage is also delayed. So both the height age and weightage of this child are delayed, but if you see, what is striking here is the weightage is much more delayed when compared to the height age. So this indicates a underlying organic cause or any other systemic disorder when the weightage is much more delayed when compared to the height age. So a short child whose weight is much more affected could be having an underlying organic disorder. So this child had symptoms of polyuria, polydipsia and tetany. Clinically she had signs of rickets, and ultrasound was suggestive of nephrocalcinosis, and she was diagnosed with renal tubular acidosis. So height age and weightage might help us clinically from the growth chart to differentiate a hormonal etiology from any other systemic disorder when it comes to short stature or underweight or failure to thrive. So this is another child whose height again is much below the 3rd centile, and if you see the height age and weightage, what we see here is both are lagging, but when compared to the weightage, the height age is much more lagging. So this child has a height age and weightage which are both delayed, and also a bone age which is very much delayed. So this could indicate an underlying endocrine or a hormonal etiology. So the height being more affected than weight could be a suggestive of a endocrine cause with respect to short stature. So next we have this 9-year-old girl whose weight, if you see, is above the 97th centile, and height also is on the 97th centile. So she is a tall and a chubby child. So if we look at the BMI chart, so this is the BMI chart that we use in obese children, the IAP chart we could use. So here we have the 23rd adult equivalent of BMI, above which we can conclude that the child is overweight, and the 27th adult equivalent percentile, above which we can conclude that a child is obese. So this child is obese with both her height age and weightage both being advanced. So when both the height and weightage are advanced, it could be suggestive of a nutritional or a lifestyle related etiology of obesity. So usually in a child with hormonal cause, the height would be affected in causes like Cushing syndrome or hypothyroidism or pseudo-hypoparathyroidism. So if you look at this male child who is 12 years old, so you see that his height is affected, he is less than the 3rd centile. His height age is delayed beyond his chronological age, whereas his weightage is much more advanced. So this is classically what we see in a endocrine cause of short stature. So clinically when we examine this child, and the X-ray of the hand was suggestive of a short 4th metacarpal, and this child was diagnosed with pseudo-hypoparathyroidism. So height age and weightage even in obese and overweight children can give us a clue to the etiology. With this we come to the end of growth charts, and we will quickly go through bone age X-ray. So bone age is another important thing that we need to look into when we evaluate children with growth and pubertal issues. So basically it assesses the skeletal growth, and the degree of skeletal development reflects the degree of physiological maturation. So it is based on the degree of bone ossification that we stage the bone age. So hand is what is most commonly taken into consideration, because that is known to represent the maturation of the entire skeletal system. So from the clinical utility point of view, it is important in growth, as in we can get to know the etiology of short stature in children with short stature, like what we discussed earlier. We can also to a certain extent predict adult height based on certain charts available for different methods of bone age, and also to initiate and to decide on the duration of growth hormone. Also the bone age is important. When it comes to puberty, diagnosis of puberty, it definitely is a supportive evidence. So a child whose bone age is advanced by more than 2 years could be suggestive of precocious puberty, and also for initiation and duration of the treatment of GnRH analogs also it would be important. So what we should remember in bone age progression is, so the maturation always occurs from proximal to distal and the fusion occurs from distal to proximal. So taking that into consideration, there are certain important areas that we need to consider in specific age would be, in infancy it would be the carpal bones, in childhood it would be the metacarpals and the epiphyses of the phalanges, whereas in puberty and late puberty it would be the phalanges, the epiphyses and metaphyses. Other important thing to remember is that in girls the bone age will be little more advanced when compared to that of boys at any particular age. So like we discussed, in infants we will have to consider the development of the capitate, hamate and radius. So if you compare the X-ray of a 1-year-old male child and female child, we see that this is little more advanced when compared to that of a male child. So again, toddlers, it would be mostly the metacarpals and the proximal phalanges that we consider. In prepubertal children, it would be the epiphyses and metaphyses of the phalanges. So we see how the development of the epiphyses is with respect to the metaphyses based on the width of this and based on the capping and then later on the fusion. In late puberty, if you see, so this is where the fusion has started, that is distally the fusion has started, whereas proximally the fusion is yet to happen. So if you are considering epiphyseal fusion, in males it occurs at around 16 years of age, where most of the epiphyses are fused, whereas in females it is around 14 years, which is a little earlier compared to the male child. So sites of radiograph for bone age, so commonest what is used is the hand X-ray, the non-dominant hand is what we use. The knee might have a role in few children, neonates with congenital hypothyroidism, where an absent lower end of femur and upper end of tibial epiphysis would indicate a more severe hormone deficiency. So next important thing is how do we do it? So most of the times when we request for an X-ray, we might get a X-ray of a hand where the terminal phalanx might be missing or the wrist might not have been radiographed. So while requesting for a radiograph of the hand, we should be very particular. We'll have to ask for a plain radiograph of the hand, the non-dominant hand, where it includes the distal end of the radius and ulna, and also all the terminal phalanges have to be included. So there are different methods. We have the atlas method and scoring of epiphysis method. Each of it has its own advantages and disadvantages. The commonest ones that are used in atlas method is Grulich and Pyle and Gilson's and Ratip. So in the atlas method what we do is we have references for various age, like for in Grulich and Pyle we have at an interval of 6 months. There is description of various stages of bones. So what we do is the patient's or the child's X-ray, we compare it with the one which closely matches the description and we conclude that as the bone age of the child. Whereas in scoring method, which is the Tanner-Whitehouse method which is commonly used, we score some areas, regions of interest and then we sum up the scores and match the score to a particular bone age. So this is how the Grulich and Pyle atlas looks like. So for a 2-year-old child, if you are taking, this is how the patient's X-ray would look like, and this is what the reference standards that is given in the atlas. So few regions we will want to study and then conclude what closely matches the patient. So important things to remember here is that some bones will mature at different rates in one patient compared to another. It may not be uniform in all the patients. And there is significantly more variability in carpal bones when compared to the phalanges. So whenever there is a discrepancy, which happens most of the times during our clinical practice, we will always have to prioritize the phalanges over the carpals. So advantage is it is simpler and faster, and it may not be less reliable, it may be less reliable in Asians. Next commonly used is the Tanner-Whitehouse 3. So here we have 13 selected regions of interest and like shown in the picture. And then what we do is we match it with 8 to 9 stages of which are described, and then we see where it closely matches, and each of it is given a numerical score which is then added up and matched with a particular bone age. So this has the advantage of being more accurate and more reproducible, but it is more complex and time consuming. So to make our work easier in our day-to-day practice, we have mobile applications which we can use. So we have the IAP growth chart which we can use on our phones and also share it with the patients. This gives the absolute height or the nutritional status of the child with respect to the height and weight, the mid-parental height and even the Z score, and it is also useful for maintaining the long-term data. For bone age, for Tanner Whitehouse 3, we have, I think many of us use this, the Eat Your Piece. So this has, this app is, which looks something like this, where each region of interest we can match it, so the each stage will be described here. We can match it with whichever matches our patient, and finally the app itself would give a score and stage the bone age. So with this I think I conclude. Thank you.
Thank you, ma'am. The session is now open for discussion.